Well, I'm Dr. Hatzidakis, and I'll be giving you a little talk on the painful shoulder and elbow. So what we're going to talk about is first how joints work. And I'm going to focus mostly on the shoulder and elbow, of course. And then we're going to talk about different treatments, conservative, operative, and then some of the new therapies that are out there that can help. So what is a joint? A slick interface between two moving parts. You can see in this joint, there's the socket, this is the shoulder. The ball's right here. There's the rotator cuff above it. And so you can see how glistening and smooth that is. It really has to be like that to allow motion. How does the joint function? Well, muscles contract to move bones. Tendons are the attachment of muscles to bones to make them move. They're a lot stronger than a muscle. They're like a rope. And ligaments are like ropes attaching bones to bones so that they stay stable. The shoulder joint is a ball and saucer joint. It's not a ball and socket joint. If it was a ball and socket joint, it would be more stable. But it's not. It allows a lot of motion. So you really have to have a design that's not very stable, that's not constrained, so that you can get that motion. And I'll show you some more on that in a little bit. Because the bony stability is not there, you need soft tissue stability. And that's where the rotator cuff comes in. The rotator cuff is a group of muscles attaching the scapula to the ball of the shoulder, the humerus, that keeps it stable. The labrum and the ligaments are kind of the check rein that at the end of motion, if the rotator cuff's not functioning, the ligaments hold it stiff so that you can't go any further and dislocate the shoulder. There are big, powerful muscles on the outside of the cuff that provide even more power for movement. This is why I say it's a ball and saucer joint. When you look at this joint, here's the ball, here's the saucer. There's not a socket cupping the ball. Kind of looks like a golf ball on a golf tee. In that view, if you flip it that way, or this view viewed from the armpit, if you just flip that a little bit, it looks exactly like a golf ball on a golf tee. And everybody knows you can just tip that off without a big effort. So you really need a labrum and ligaments. This is the labrum. It's an inner tube cartilage around the socket, or the saucer. It makes it a little bit deeper. And it also attaches to the ligaments that really are loose when you're just sitting here relaxed, but when you get your arm out to the extreme, they tighten so that the shoulder doesn't pop out. The next layer is the rotator cuff. The rotator cuff is attached to the scapula, here, your shoulder blade. There's a strong muscle in the front, top, and back, surrounding the ball of the shoulder, making a cuff. Then on the outside of the shoulder is the deltoid, the pec, some really big muscles that provide lots of the power. But without this group of muscles that are smaller in comparison, but are much closer to the joint, making it much more stable, you don't have a shoulder that functions very well. You need to have both. These muscles that keep the ball stable on the saucer, and then these muscles to really power it once it's stable. So here's how the arm lifts at the shoulder. You can see the scapula, the shoulder blade here, the ball of the humerus right here, and you can see how both joints move. The scapula moves between the chest, or on the chest, and then the ball moves on the socket. The shoulder, even though it's very complicated, to me, and I think if you just think of it simply, you can make it simple in your brain. The ligaments can tear, making instability. The ligaments can become stiff, making a frozen shoulder. The muscle attachments or tendons can become irritated, causing rotator cuff tendonitis or bursitis. The muscle attachments, the tendons, can also tear. Most people have this, tendonitis, but some people do have tears, and the treatment is somewhat different. Now let's leave the cuff. The joint surfaces, they can deteriorate, causing arthritis. The tendons can tear extensively also, and arthritis can develop at the same time. So that's kind of a double whammy and difficult to treat. So first, ligaments are torn, causing instability. The shoulder dislocates. When you do activities, your shoulder feels like it's going to pop out. You can see the ball's not on the socket there. And usually what happens is the labrum, or soft tissue, tears away from the socket, making it unstable. Now, we've really had advancements in conservative treatment, and we don't know the long-term results of this, but there's some promising early results of a new type of sling that keeps the arm slightly externally rotated. Now, the reason being is that when you internally rotate your arm in a standard sling, the arm points towards the back, but more importantly, the front cuff muscle becomes loose, and so there's a big space up in here. If you keep the arm in external rotation, the front muscle gets tight, the ligament comes down to the bone. And we've seen some early results with instability, better results with sling treatment. The old studies show that if you're 20 years old, less than 20 years old, the rate of dislocation is very high as 90%. But with some new studies of even military recruits, a very active young population, that rate has been dramatically decreased, at least in the short term, and some good studies from Japan and America. If conservative treatment doesn't work, physical therapy to strengthen the rotator cuff, special sling treatment, you still have an unstable shoulder, you can repair the torn tissue surgically. And you do that by releasing the subscapularis, the front cuff tendon. You go in and either use anchors or small holes through the bone to suture the ligament back down to the bone. Then you can tighten the capsule also if you like. But you have to cut the muscle to get in there to do it, in most cases. Now this is where I'm going to start talking about minimally invasive surgery. This symbolizes open surgery, this is arthroscopic surgery where you use a small slender camera to go into the joint. You don't cut any muscles. And small arthroscopic instruments, anchors, sutures to fix things. Here's an arthroscopic view of a normal shoulder viewed from the back. So here's the ball, and the socket is right here on the bottom part. These are the ligaments that attach the socket to the ball. That kind of comes around like a big curving curtain. I'm taking a probe to stress those ligaments, and they're intact. They're not torn. It's normal. This is the anterior band of the inferior glenohumeral ligament for the PTs in the audience. So this is a 19-year-old kid who was horsing around with his buddies and fell over a box. And this is what he did to his shoulder. He tore his labrum at the top, causing what's called a slap tear or superior labral tear, and then tore the front of the labrum as well. Are you going to pass out or anything? No? Oh, I have some open surgery later. You're going to make sure and close your eyes for that. Yeah. So the nice thing is that you can use a camera to go in and look at it, and then use special small instruments to put sutures in to fix that torn labrum down to the bone. And I prefer to use all absorbable sutures for the inside of the shoulder because I've seen a few cases where metal anchors have been used where they cause arthritis. So I use all plastic sutures and anchors. The benefits of arthroscopic repair is that they're small incisions and no muscle is cut. That can also be dangerous because people feel better faster, so you've got to hold them down a little bit. But overall, the recovery is usually more pleasant. For instability, I think it's really nice because if that front muscle tears because someone does something they shouldn't have done, you haven't done something really bad. Or that's really bad for the shoulder. If you do it arthroscopically, you don't get those tears. So you can't really do that. You can re-tear the labrum, but you can't tear the muscle. So here's the next problem with the ligaments. They become stiff. It's the opposite. They contract. They become tight and thickened. Usually this is for no reason. There's no injury, nothing. It just happens out of the blue. Limited motion with a painful, stiff shoulder. This guy has limited range of motion of his shoulder, especially in rotation. You can see him grimacing here. Conservative treatment usually works for this problem. A nicely placed cortisone injection with a gentle stretching program. It's not a no pain, no gain thing because there's been a good study recently from the Netherlands that showed that people who do a no pain, no gain stretching program do worse than people who do nothing for this problem. So he did a gentle stretching program, regained most of his motion, not quite full rotation, but you can see he's not grimacing quite as much. So that's at 6 weeks after a cortisone shot and with a stretching program. Most patients that works, but occasionally you have to do something like a manipulation where you have to get to sleep and move the shoulder gently to disrupt some of the adhesions and actually tear the capsule in most cases to get motion. These are my biceps, by the way. I haven't worked out in a little while, so they've shrunk a little bit. So, moving the shoulder gently, usually you hear a pop, pop, pop. Sandy, don't pass out on me. Now, that can really work in a lot of patients, especially if it's easy to do. If it's hard to do, sometimes you risk tearing structures, breaking the humerus, and you can get, basically after a manipulation, a lot of blood in the shoulder. You really tear tissue to get it to move. And that's not very precise sometimes. So what I like to do in cases that are difficult especially is to actually use a little bit of the manipulation, but especially if it's too tight, you go in surgically and you remove the capsule. You release and remove the capsule. And this is especially helpful for diabetic patients who are especially hard to get better with conservative treatment. So basically it's a little biter, removing some of the capsule of the shoulder so that basically the ligaments don't keep the shoulder tight anymore. Does that make sense, Sandy? I'm going to pick on you a lot because you're right there. Yeah. So here's a guy who had diabetes who had actually had a decompression surgery. He's gritting his teeth, not smiling. Yeah. And basically said, I didn't get better. What's going on? Well, he probably had the wrong operation. He basically can't move his shoulder. This is after an arthroscopic release. That's 3 months after surgery. I just saw him at his 2-year follow-up. He's still got the same motion. and he can bowl and do the activities he likes to do. So I think that's especially helpful for your really hard cases to treat. Rotator cuff irritation, bursitis, impingement, bone spur, they're all part of the same problem. Okay? And so just consider the same when folks talk about it. It's very common. I see a lot of it in my practice. There's pain in the shoulder, spreading down the arm, but not usually past the elbow, but although it can go almost to the elbow sometimes. Pain at night and with overhead activities. Now in these cases, by definition, the rotator cuff is not torn, although you can still have the same symptoms of a torn rotator cuff, and it's difficult to tell the difference between the two sometimes without an MRI. So what is this bone spur people talk about? Well, this is kind of a normal shoulder with a normal roof over the shoulder. But sometimes if you have a big spur like this, the rotator cuff gets pinched. Now I have to add a caveat to that. Some people with normal, non-painful shoulders have bones like this, but if the rotator cuff gets a little bit inflamed, a little bit larger and swollen, it can start impinging on that spur, and so then you get into this chronic inflammation process. You can treat that successfully with conservative treatment in most cases. Physical therapy, a stretching and strengthening program. Most patients with this can't get their hand behind their back. Got to work on that stretch in particular. Anti-inflammatories can help. Cortisone shots can also help. Most cases do not need an operation. In fact, the official academy stance on getting a decompressive surgery without a rotator cuff tear is 6 months of conservative treatment failed. That's the official stance. If conservative treatment does not work, an arthroscopic subacromial decompression or bone spur removal, removing this bone spur here with a little burr, can help because you raise the roof over the rotator cuff, making more space for it. I'll show you a little surgery here that demonstrates that. This is the undersurface of the acromion or roof right here. This is the bone. This is the rotator cuff that's frayed and damaged. There's actually a rotator cuff tear in this case. So I'm kind of cleaning away the soft tissue so you can see there's this big spur sticking down into the subacromial space, not much space for the cuff. Over here we're showing using a burr coming from the outside of the shoulder using a small incision to remove that bone. And at the end you're going to see there's a lot more room for the rotator cuff. And surprisingly, you don't have to remove very much. This is only about a 5 millimeter burr. So you're only removing about 6-7 millimeters of bone. And then you have a lot more room for the rotator cuff, getting something like this. Okay? So that's removing the spur. That's the secret. Rotator cuff tears. This is the top rotator cuff muscle, the supraspinatus. This is an MRI. Same symptoms though, pain in the shoulder and arm, night pain, trouble with overhead activities, usually a little more weakness with the rotator cuff tear, although not always, so it can be confusing. The amazing thing about rotator cuff tears is that they're very common and oftentimes not even felt. This pie graph demonstrates a study where they took people with knee pain who were over 60 years old and MRI'd their shoulders. No shoulder pain. They found 28% had tears of the rotator cuff, full thickness tears. 26% had significant partial tears of the rotator cuff. In fact, less than 50% had normal rotator cuffs. So a lot of folks have tears, they don't even know it, or it becomes symptomatic later in life. You sit around with it for a long time, it doesn't become symptomatic until later in life. Conservative treatment can help. Physical therapy, stretching and strengthening, anti-inflammatories, a cortisone shot can help. But the caveat to this problem, as opposed to simple bursitis or impingement, is that the tear can become larger over time. It's like a hole in your pants, in your favorite pair of pants usually, that you want to keep wearing. Well, you can get caught on things and then it gets bigger and bigger. That can happen in the cuff too, and it's more difficult to repair when it gets bigger. There are different sizes of rotator cuff tears. This is what we would call small tear. This is a medium tear. This is a large tear where it's retracted to the socket. No coverage over the top of the humeral head. A good study from St. Louis showed that about 50% of tears become larger and more painful after 3 years in a group of asymptomatic patients. These were patients who had contralateral or other-sided rotator cuff tears. They looked at their other shoulder, the one that wasn't symptomatic, and they found tears. They followed those patients over time. They found 50% became symptomatic. Larger tears are harder to repair, and they have lower healing rates after repair. So that's a reason to potentially fix the rotator cuff, especially if it's symptomatic, because if you let it go, you can get to a point where it's not repairable. The problem is you don't know. You could also let it go, and it could still be repairable 5 years later without any enlargement, but you just don't know because you can't read the future. So here's a traditional open repair where we make a split in the skin, a split over the deltoid, that big muscle on the top of the shoulder, and then get to the rotator cuff tear, which is this hole right here. You can use a small burr to beat up the bone a little bit to make it bleed, which encourages healing, and then suture the tendon down to the bone. Here's an example of a typical incision for a open rotator cuff repair. Now these tears can be repaired arthroscopically. We've perfected techniques to look at the rotator cuff, to see the hole in the cuff, prepare the bone, and fix it with suture anchors down to the bone. And so this is the hole in the cuff. This is a burr to debride some of the greater tuberosity or the attachment of the cuff. You can see it's covered with scar tissue. That doesn't want to heal very well. So you try to make it raw and make it bleed so that it will heal. So there's the hole in the cuff. You use a special grasper instrument to pull it down to the bone bed, and then use a special hooked instrument to pass a suture through the cuff. You try to get a big, nice, thick bite of cuff and pass the suture through it. There's a grasper grabbing the suture, and then you drill a small hole. This is about a 2 millimeter drill bit. It looks a lot bigger on this screen, but it's pretty small. And then putting in a small anchor into the bone with the suture attached. You tie special arthroscopic knots and advance them into the joint through your little plastic cannula that you have in the joint, and then you have your first stitch in the cuff. You repeat that step until you have a very strong and stable repair. And there it is. You can rotate it back and forth, and it really seems stable. You still have to protect this afterwards to let it heal, because any repair that we do is not even close to the strength of a normal tendon. So this has to heal over time to get the best result. The benefits: small incision, no muscles really cut. You just make small splits in the muscle, which really heal up a lot faster than if you have to make a big cut in the muscle over the top to repair the cuff. So number 5, arthritis. This is when the joint surface deteriorates. A lot of folks come in with me saying, I have shoulder pain because I have arthritis. Most people do not. It's usually rotator cuff, tendonitis, bursitis, or a cuff tear. Rotator cuff problems are much more common. Arthritic patients have a lot more locking, catching, and grinding. They have pain, weather-related pain with weather changes, as well as pain at night, not letting them sleep. And that also does occur with rotator cuff problems. Once arthritis develops, it cannot be reversed. We have no cartilage substitute that actually coats the bone with new, good joint cartilage. The rotator cuff is almost always intact in these cases. Here's a normal x-ray once again, showing a normal shoulder joint. Good joint space. The rotator cuff is on top. You can't see it, but you can see that it's probably intact because the ball matches up with the socket. It has not gone up in the socket that you can get with a big rotator cuff tear, which I'll show you in a second. Can everybody see the difference between that shoulder and the one on the left? There's no space here. The roundness has gone away. It's flattened. It's collapsed. And you can understand how that would cause pain. It catches. It doesn't rotate correctly. It doesn't work as well. But the cuff is intact, which is nice because you can reconstruct it with a total shoulder replacement and make it function nearly normally in some cases, many cases. So here's a normal joint, the socket, the ball, good glistening articular cartilage and surfaces. Here's an arthritic shoulder. No cartilage left. It's flattened. We call that eburnation. There are big bone spurs. We call them osteophytes. It looks more like a head of cauliflower than a shoulder, usually. Here's a case which didn't make a lot of osteophytes, but you can see there's no cartilage left. It's just down to the bone. And that bone on bone hurts. Conservative treatment can help. Rest, anti-inflammatories. Glucosamine chondroitin can help some patients. Cortisone injections. Viscosupplementation, which is the rooster coat cartilage injections, which is kind of like a lube job for the shoulder. It really doesn't add new cartilage, but it makes it slicker inside and may increase joint fluid. That's not approved for the shoulder right now, but you can do it for patients. I do it in some folks who are young, who need a replacement, who want to delay it, and they understand that it's not FDA approved. And decreased activity can help the discomfort. Now, shoulder replacement can really help with these folks who fail conservative treatment. The reason why it works is because that plastic socket, which was just showed there, articulates with the metal ball. And that metal on plastic is a lot smoother than bone on bone. So here's a shoulder replacement being impacted into position with cement. Here's the subscapularis insertion, the rotator cuff that's released that has to be repaired at the end. Very gently tap the prosthesis into position. And then you have a metal on plastic articulation that's much smoother than their bone on bone. There are a lot of myths about shoulder replacement. Shoulder replacement only improves pain. Function doesn't improve much. Range of motion doesn't improve much. They don't last very long. I've heard a lot of these from different patients coming in to see me. This is the only part that's correct. Consistent, reliable pain relief with total shoulder replacement in over 90% of patients. Average gain in lifting the arm of 45 degrees. So that means going from about here to about here on average. So there is function that's gained, range of motion that's gained, rotation of 30 degrees out to the side, and rotation behind the back usually improves as well. And then excellent intermediate and long-term survival. 93% survival at 10 years and 87% at 15 years in the longest term study that we have. Well, what's new in shoulder replacements? We really have benefited from anatomic replacements, and Tournier, one of the sponsors, is one of the booths out there that makes this type of prosthesis. It's a prosthesis that fits the native shoulder bone better. This is an old prosthesis. You can see that that doesn't really look right. My professor during my fellowship used to call this the junior mint prosthesis because it looked like you're just sticking a junior mint on top of the head. You don't want that. You want something that's more anatomic, that fits the bone correctly, that restores the tension and the relationships of the rotator cuff to the bone. And these typically function better and over time. There are a lot of complications with shoulder replacement that can happen. Luckily, the rates of these complications is very rare. Infection, blood vessel damage or nerve damage, instability, fracture, tendon rupture, loosening, stiffness or weakness, and continued pain and disability. In the hands of an experienced shoulder surgeon who does a lot of these are very low. The rate of infection, less than 1%. These, almost non-existent. You can always fall on the shoulder very hard and fracture it, but intraoperative complications was what I'm talking about, very low. That has to be kept, in mind in regards to who does your replacement, because complications have been shown to be 50% less if the replacement is performed by a surgeon who does more than 30 replacements per year. Also, shorter hospitalization times are noted, and even decreased mortality in one study. The unfortunate thing about this is that about 3/4 of all shoulder replacements are performed by surgeons who do 1 to 3 a year. So that's up to patients and finding out, doing their homework, and talking to their surgeons and being comfortable with that. So number 6, the final big problem. This is the grand kahuna of shoulder problems. Arthritis with a bad rotator cuff. Double whammy. Pain, grinding, catching, and a lot of weakness. You can see this guy can barely lift his arm at all, about 20 degrees. And what you do in this case is that you have no rotator cuff. The shoulder hikes up instead of rotates. You do this instead of doing this. And you can see that's what he's kind of doing there. You can see the tip of his shoulder is kind of hiking up. The reason being is that without a rotator cuff, the shoulder kind of goes up in the socket until it hits something. Usually that's the roof. Sometimes it goes ahead of the roof and it sticks out underneath the skin, especially in folks who've had previous surgery. But you can see here, here's the ball, here's the socket. That doesn't look right, does it? So that's what happens. It makes the shoulder ineffective. Now, conservative treatment can work in some selected cases. Rest, anti-inflammatories, glucosamine chondroitin, cortisone shots, strengthening, and even an arthroscopic cleanup procedure can occasionally help. A half replacement of the shoulder can work as well. The theory is that if you put something smooth there and it's not bone on bone, you have better ability for the remaining muscles to compensate for the lost muscles, and then the shoulder can work. And this is a patient of mine who it did work on. He had excellent function before surgery, excellent motion, but a really bad rotator cuff. So I put in a simple cap replacement, and he's happy with that. He has good pain relief. This is a lady that's not happy with a half replacement. The replacement looks good, looks pretty anatomic, but she can't lift her arm and she's having pain. This is a 86-year-old lady that came back to me 2 years after having surgery saying, I want more surgery. Now, 86-year-olds usually don't want surgery. It's the last thing they want. So they really got to be hurting to want to come in and get something changed. Well, what's new in this field is a reverse shoulder replacement. I had the opportunity to work in Europe for 9 months, learning more about this prosthesis before it was approved by the FDA 2.5 years ago here in this country. It has the ball on the socket side and a socket on the ball side. That's why it's called reversed. So when you look at an X-ray, here's the ball on the scapula and the socket's in the humerus. The reason why that works is because the shoulder doesn't go up anymore. It stops the shoulder from going up because this socket kind of locks onto this ball. So now, despite the fact that there's no rotator cuff, you can't replace the rotator cuff. The deltoid, the bigger muscles on the outside of the shoulder, the pec, the biceps, those muscles can all help lift the shoulder. So here's an example of what that looks like. This is a person with a deficient rotator cuff. You can see on the X-ray that the socket is moving on the ball and the scapula is moving. Both things are moving, not just the scapula. So just take another look at that. You can see it rotate on the ball right there. And then the scapula moves to get the rest of the motion. And so you can take patients who have no motion, 20, 30 degrees, and they can actually look like this patient on occasion. Nice little lady in France that I got to talk to about her reverse prosthesis. So it really stabilizes the shoulder so that it actually rotates, not just hike up. And the deltoid and the other muscles that are intact that usually don't tear can compensate for the complete lack of the rotator cuff. Here's a lady from Western Kansas that came in, bad rotator cuff, bad arthritic shoulder. I can't lift my arm, I'm miserable. This is 3 months after surgery. Doing a little bit better. So we'll talk a little bit about the elbow, and then we'll have some time for some questions. The elbow is a much simpler joint than the shoulder. It's just a simple hinge joint. The hinge is at the ulna. There's a rotating radius that actually rotates your wrist back and forth. So this little ball here rotates on the humerus. Problems with the elbow are rare. Maybe it's because it's a simple hinge joint that's very stable. The main thing I see in my practice is tennis elbow, and that doesn't really come from the elbow, it comes from the wrist. And then arthritis I do see in the office, which there are many new options for as well. Tennis elbow, the muscles from the elbow to the wrist become irritated with everyday activities. Basically, these muscles here, which attach to the outside of the elbow, go all the way to the wrist. When you lift it up, every time it stresses those muscles. When you use a hammer, when you play tennis, all kinds of things. The tendon tends to degenerate over the end of the epicondyle, or the bone. So it hurts, it's tender there, but also you have difficulty with wrist activities. Conservative treatment luckily works in most patients. Rest, stretching and strengthening, anti-inflammatories, physical therapy, ultrasound, massage, and strengthening of the wrist. A tennis elbow strap, a little strap that you wear over the elbow, can work. And over 90% of cases treated appropriately with conservative management, all of these different things, get better. What about the patients that don't get better? This is a new treatment that's out. We don't really know the long-term results of this, but we have some encouraging short-term results. This is not a laser. It's an ultrasound machine. It's kind of a similar technology to the technology that breaks up kidney stones. It sends high-energy pulsed ultrasound to the area of degenerative tendon, stimulating some tissue damage and then repair. So the jury's out on this, but this is a potential way to avoid surgery in the refractory cases that are not helped with therapy. Conservative treatment doesn't work. You can also do open surgery, which is kind of the standard of care. Short incision over the outside of the elbow. You remove irritated and diseased tendon, and you see improvement in over 90% of cases. But you do split some muscles over the elbow that requires healing afterwards, so it takes a little while to be able to return to full activities. A new treatment is arthroscopic tennis elbow release, where you actually look inside the elbow. You make small incisions, you look inside, and you look right at the diseased tendon because it's deep in the capsule, and you actually release and debride that tendon. Typically, patients with this type of surgery heal a little bit faster than open surgery. There hasn't really been any other benefit, but it is a little bit of a faster healing process, and you can look at the rest of the elbow and see if there's any other pathology in the elbow. This is a little more serious than tennis elbow. This joint's completely destroyed. The most common cause of elbow arthritis is rheumatoid arthritis. But the secondary cause is osteoarthritis or just wear and tear. Conservative treatment, rest, anti-inflammatories, glucosamine chondroitin can help, and cortisone shots. If conservative treatment doesn't work, an elbow replacement can help. Now we're making newer, more anatomic elbow replacements with better bearing surfaces that probably will have a little better function than the older replacements that we've had in the past, but we don't know that yet. And this can be a reliable relief for folks with elbow arthritis that can essentially relieve their symptoms. You can also do an arthroscopic surgery or cleanup procedure, make small incisions, remove inflamed tissue, particularly in rheumatoid arthritis, release the capsule and ligaments to get more motion, and in osteoarthritis, often there are big bone spurs and loose bodies that you can take out and improve a patient's symptoms and avoid an elbow replacement. Here's a patient with rheumatoid arthritis. Usually when you go in an elbow, there's nice clean capsule. In this case, there's a lot of synovitis, irritated tissue, globular, irritated, reddened, thickened tissue that you can actually see on an MRI even if you look at it. Use the shaver to remove that irritated tissue from the joint. Right now you can't see much of the joint itself. you're seeing more and more as you remove the irritated tissue. There's the globules of tissue there. And you can actually see that radial head better after removing that irritated tissue. This is the bone. The irritated tissue with those small globs of, and you don't see that unless you have rheumatoid arthritis usually. They're synovitis. It's the synovium which makes your joint fluid. Instead it makes inflammatory fluid, and it makes more tissue, and it makes big globs of tissue called pannus, and it eats away at the cartilage. In an osteoarthritic patient, a patient with wear and tear, a lot of times you'll find these loose bodies, or they sometimes call them joint mice. There's a big loose body in the elbow that was catching on this electrician's elbow when he was doing activities. In fact, it was catching on his ulnar nerve, so it was causing numbness and tingling in his fingers. You can use a grasper to take that out without too much difficulty, and these folks they come in 2 weeks later and say, I'm better, see you later, doctor. So that's pretty rewarding. So in summary, shoulder and elbow pain is usually a problem with the ligaments, muscle tendons, or joint surfaces causing arthritis, like in this case. Most problems can be treated effectively conservatively, and advances in operative treatment have led to less pain, faster recoveries, and better results. Thanks. Making patients happy. This guy actually couldn't lift his shoulder, and after his replacement, his biggest happy thing in his life was he could put his arm around his wife again. So he couldn't do it before. I guess it hurt too bad. So I think my time's up. Thanks for coming.